Hello, we'll get started. Welcome to the Alliance for Academic Internal Medicine Health Inequities mini-series, and the first webinar titled The COVID Crisis and Health Inequities, What Clinicians Should Know and Their Role as Change Agents. So I am your moderator, Dr. Siobhan Onama. I am an internist, director of the primary care clerkship, as well as an HIV and internal medicine pathway director, and the director of the Diversity, Equity, and Inclusion Council for the Department of Medicine at the George Washington University School of Medicine and Health Sciences. Here at Alliance for Academic Internal Medicine, I've served on AIM's Diversity and Inclusion Committee and currently on the Diversity, Equity, and Inclusion Work Group, as well as the CDIM Survey and Scholarship Committee. And I am really excited to have you all here joining us today. I think we have a great talk in store. But before we begin, I do just want to acknowledge that I know it took a lot for a number of us to be here with everything that's going on right now in our nation, from natural disasters to, we're in the midst of a pandemic, of course, and then we have racial tensions and, repeated incidences of racism, and it's a lot. So for you all to take the time to be here and to learn about COVID and the inequities and what we can do to be better, I just want to commend you all for being here today. So we'll start off with a few introductions, get to know a little bit about our audience, and then we'll have the faculty presentations by two dynamic speakers for the first 50 minutes, and then we will have some time for questions and discussion, hopefully a lively discussion, and we'll share resources for you all to use at your home institution and communities as well. So the webinar objectives include defining health inequities to make sure we're all on the same page, reviewing the impact of COVID-19 on health inequities across the U.S. healthcare system, identifying and understanding the challenges these inequities present to departments of medicine. We're going to review the strategies for how faculty, staff, and learners can begin to address these challenges. So hopefully coming up with some solutions here. All right, so before I introduce our speakers today, we're going to start off with a couple of poll questions. Which of the following statements apply to your experience with the COVID-19 pandemic? Select all that apply. That's the first question. And the second question is, which of the following types of inequities of care have you personally witnessed as a provider or administrator during the COVID-19 pandemic specifically? Select all that apply. So just wait for some more responses here. All right, we'll see. So it looks like majority of you, 57% of you know someone personally who has been hospitalized with COVID-19. Others, people have died, and you've cared for patients. 57% have cared for patients who have died of COVID-19. And as far as the inequities that you've witnessed, 63% have noticed the disproportionate number of patients of color hospitalized or seriously ill with COVID-19, as well as inadequate testing for minority populations and inadequate patient education. So certainly, it's correct that we do not have an NA section here, but certainly a number of you are aware and have witnessed personally some of the inequities facing us today. So we'll move on, because I think we're going to tackle a number of different things in this talk. So without further ado, I want to introduce you to our speakers today. Dr. Jihan Gigi better known as Gigi El-Bayoumi, actually received her bachelor's and master MD degrees from University of Michigan. After completing her internal medicine residency and chief residency training at the University of Michigan, she actually came to the George Washington University. After completing her medical school, she came to George Washington University to complete her internal medicine residency and chief residency. And then she stayed on as a faculty member as an academic internist. Her career has been focused on medical education, and she served as an internal medicine clerkship director for 5 years, and then program director of the internal medicine residency program for 15 years. And she transitioned roles in 2013, where she started the Rodham Institute, which was named for her late patient, Mrs. Dorothy Rodham. And it was dedicated to improving health inequities improving health equities in Washington, D.C., which many, if you don't know, you will know that D.C. suffers from some of the highest per capita poor health outcomes in the country, unfortunately. So you'll hear a little bit more about Rodham Institute's work during the COVID or the current pandemic, I should say. But notably, prior to the pandemic, the Rodham Institute has had several programs, including the HELP program for middle and high school students from Title I schools, as well as the See the City You Serve, which introduces incoming interns to the city that they will be training in, and has been adopted by several programs nationwide. So certainly serving as a pillar in our communities. And then we have Dr. Joshua Anthony, who has dedicated himself to reducing mental health stigma and reducing health disparities. He is an American Psychiatry Association SAMHSA Minority Fellow and an HBCU Cares Behavioral Health Ambassador. Dr. Anthony earned an MBA in Healthcare Management from Northeastern University. And he has been using his voice to reach underrepresented communities as a social media influencer that leverages his identity as the therapy doc. He increases awareness around mental health issues through engaging content that is relevant, funny, and culturally competent. So we're going to be looking forward to hearing from both Drs. El-Bayoumi and Dr. Anthony. And again, this webinar is the COVID crisis and health inequities, what clinicians should know in their role as change agents. Thank you, Dr. El-Bayoumi.
Good afternoon, everyone. And I just had a little, I'm going to wait for Dr. Onoma to go ahead and close her screen before I start my screen. And here we go. Like Dr. Onoma, like all of us, I think we have really been impacted by what I call the two pandemics. And in starting, we're going to start now. Hopefully you can see my screen, which is here. I want to tell you a little bit about the Rodham Institute, as well as my take on the two pandemics. As Dr. Onoma mentioned, I do have I've earned my street cred in that I was a program director for 15 years, 108 residents, 65 fellows, training in 4 different hospitals, including the NIH. So I'm familiar with the challenges that we collectively have as lifelong learners, but also educators and clinicians. The Rodham Institute is dedicated to improving health equity in Washington, D.C., partnering together to improve the health and well-being of all of D.C.'s residents. Our goal is to create a model that is sustainable, that does not replicate, that shares and allows other people to replicate this model. So everything that we do is free, and you are welcome to go to our website. Feel free to email me, and anything that I can do to share, I'm more than happy to do this. Well, Washington, D.C. is beautiful. When I came to D.C. all those years ago, we were actually at the start of another pandemic. But now we're faced with the COVID-19 outbreak, which is of course a global disaster, But like any other social, economic, or health crisis, it is the people of color and low-income people that are hit hardest. And unfortunately, coronavirus is just the latest example of health disparities. What the COVID crisis has done is really lifted or unmasked the inequities that have existed all along. I was struck by the statement that Dr. Cuomo made. Why are more African Americans and Latinos affected? The people standing on those rooftops were not rich white people. I think he was alluding to Katrina, ironically, which happened, Hurricane Katrina, almost 15 years ago to the day. And of course, unfortunately, our brothers and sisters in Louisiana, as well as Texas, are beginning to feel the brunt of Laura. It always seems that the poorest people pay the highest price. Why is that, whatever the situation is? And he said, we've got to do research about this. Our mayor, Muriel Bowser, said the virus has put a spotlight on the disproportionate number of African Americans who suffer from chronic disease, and it's also put a spotlight on the health disparities that have plagued African Americans for generations. And then finally, Dr. Fauci, which I really would like to read this out loud to you. He says it's not that Black people are getting infected more often, it's that when they do get infected, their underlying medical conditions, those are the kinds of things that wind them up in the ICU and ultimately give them a higher death rate. I see a similarity to the AIDS crisis because health disparities have always existed for the African American community. But here again, with the crisis, how it's shining a bright light on how unacceptable that is. And finally, when all of this is over, and as we said, it will end, we will get over coronavirus, but there will still be health disparities, which we really do need to address in the African American community. So I think that Dr. Anthony Fauci should be nominated for the Nobel Peace Prize. He is a personal hero, and I hope that you will be convinced, for those of you that are not old enough to remember him from his younger days, that by the end of this presentation, you will see why. He's a scientist, a physician, a researcher, a public health advocate. He recognized in the AIDS epidemic the importance of community engagement and is a real humanitarian. And here he is, I think 40 years ago, when he was 40, he always looked quite young. And our residents have the honor of actually rotating with them. A resident that was on the NIH rotation sent me a picture of him rounding. So in the midst of COVID, he's still seeing patients. He is still, advising the sixth president that he's advised and trying to do right by our country. So this is really an iconic photograph. The person on the extreme left is a patient, a human being that's dying of AIDS. And this was the first picture, I think, that grabbed the public. And this was what the face of AIDS in the 1980s looked like. My internship began in 1985. At that time, our hospital was, I mixed that up, was 600 beds. It's now 300 beds at the time. And we were always, it's 300 beds now. It was 600 at that time. And we were always full of people boarding in the emergency department. And when I was at Michigan, I remember when there was the first patient who had AIDS. It was like Ebola. Everybody was dressed in a spacesuit. We didn't know what it was. There were different ways that people, referred to it. It was first a gay bowel disease, then HTLV when they isolated a virus. People who suffered from AIDS really were very socially isolated. Clinicians refused to care for AIDS patients. I remember dentists and doctors who refused. And of course, nurses were the heroes, as they always are. And if you haven't seen the documentary out of San Francisco General, I would really suggest that you see it. And as always, the wealthy had the best access to testing and emerging treatments. So does this sound familiar? It should. The differences with the AIDS epidemic is that the one-year mortality was 100%. Of course, we didn't know what the mode of transmission was at the beginning. We were drawing labs, putting in central lines, doing LPs. I have actually later found out, like in the last couple of years, that my parents were scared stiff, but never said anything to me because they felt that's what being a doctor is all about. Certainly, because of how our planet has become much more interconnected, the science and understanding of COVID has rapidly been ramped up. I mean, it's very, very different. I mean, to be able to sequence the COVID virus, to be able to look at the possibility, or there are clinical trials now. I mean, and then the entire world is kind of experiencing this in real time and all at the same time. This was the reality for us. I mean, I can't tell you how many people I pronounced dead, how many people I was the only person with them when they died, how many people, mostly gay men, died by themselves, were excommunicated from their families, how many times I was asked to change the death certificate, just horrendous. This was the AIDS quilt, which I don't know if you can appreciate how huge it was, but we actually, in the time that we did have off, we would go down to the mall and look and find people that we knew. And it was a way of honoring the AIDS patients. And I can tell you, to this day, I still have a list of people that died because I don't want them to be forgotten, even though some of them may have been forgotten by their families. Very, very lonely deaths. And at the beginning, I should tell you that food was left outside of their rooms. People were afraid to touch them. I remember as an intern, there was actually a football player from the NFL team of Washington, D.C. And I went in, it was the middle of the night. I was at Holy Cross Hospital, 2 a.m, and he did not have very good access. I ended up having to draw blood from his foot, believe it or not. And he said, he started crying. I said, "Why are you crying?" He goes, "You're going to touch me? I have AIDS." I said, "Of course I'm going to touch you." But it was that unusual and that isolating and that lonely. Now there's COVID. We are experiencing 2 pandemics simultaneously. COVID and what I call the racism pandemic, that is, of course, we're having an acute exacerbation. It's over 400 years old. And again, we are a captive audience. And really, the silver lining of all of this, it's a disaster. And, we're pushing 200,000 Americans who have now died. And I believe that's an undercounting, because I don't think we're counting people who may have died in nursing homes, or the non-COVID patients who have died as a consequence of not seeking care. For example, at the very beginning, it was estimated that in the first 3 months, there was a 30% excess death rate in the field, people just not getting to the hospital, dying at home. And now we certainly have seen a precipitous drop in cancer diagnosis, which of course we know is going to lead to an increased mortality. But this does give us an opportunity to get educated together. Hence this AAIM webinar series. And I really want to thank and commend AAIM for putting this on, and the timeliness of this series. I'm just going to say that although I'm speaking to you, I am not by any means a person who has all the information, all the answers. I'm learning with you too, and I hope to learn from you at the end of this webinar, or at the end of the presentations, when we have a chance for questions. Statistics don't tell the entire story. 1 in 3 African Americans know someone who has died of COVID-19. As the poll that was just done showed, we are touched, but in the African American community, of course, we as clinicians, we would expect to be impacted, right? But in the African American community, there are people who have lost entire families. Patients die alone, and I can tell you that for a week in May, I was a hospitalist taking care of COVID patients, and I'm mostly outpatient. Before I was a hospitalist, I had a patient who I've been taking care of for, 30 years. He was a police officer who had diabetes, and he had declined insulin because his brother had died of diabetes, and he associated his death with starting insulin. So imagine having to tell his fiance and his daughter that he's not doing well. And at that time, remdesivir was something that was really been, how should I say this diplomatically, not distributed equitably across all of the hospitals. And our protocol at the time was to have it only for patients in the ICU. He was quite ill. He had declined going to the ICU. He was sort of tired. It was very difficult to have that end of life conversation with him and his family when they weren't there. Fortunately, I have a wonderful colleague, Dr. Juan Reyes, who is the hospitalist division director, and we were able to arrange a 4-way call with a patient, his family, myself, I guess a 5-way call, and Dr. Reyes, where he was very clear about what his wishes were. All of the support systems that we have as a society, but especially to families that are facing the death of loved ones, have come to an abrupt halt. I mean, we are human beings. How we've evolved over the millennia is that really we interact, our respective dopamine that bathes our brains actually go up when we talk and communicate. We are social beings, and to not be able to have the comfort of hugging, holding, being in other people's presence during this very difficult time, let alone for somebody who's experiencing a tragedy, is terrible. Places of worship have closed but have pivoted and are doing virtual services. But one of the real tragedies has been, and it's disproportionately affected the African American community, is the rising rate of suicide and depression among African American youth. This has been something that was happening before COVID, but there's been a dramatic increase. And I didn't include this in the slide, I wish I would have, but when we first started 7 years ago at Rodham, the first thing that we did is we commissioned a study that was done by one of our colleagues who's a community health worker in sort of the poorest sections of DC. And we wanted to know what the health priorities are of people who are almost entirely African American that live in those areas, what their health priorities were. And it weren't the health priorities that we in the public health or medical systems or healthcare systems see of HIV or cancer or diabetes or obesity. Was mental health. So this is something that's been made even worse. And the struggles of every vulnerable group have become magnified. And I'll just tell you that children, people of color, elderly, people with disabilities, LGBTQ, undocumented, people with mental illness, any other group under strain. And I will tell you that women, I should put that group in as well, every one of us will eventually be in one of these groups. Some people will have multiple identities. Here in Washington, D.C., now mind you, we're about 850,000 people. Of course, we've got the surrounding states of Virginia and Maryland. So our confirmed cases right now are about 14,000. 10,000 or 11,000 have recovered. 604, I think as of this morning, is actually 605 people have died of COVID. But the proportion of deaths among African-American residents is 84%. Although Washington, D.C. was Chocolate City when I first moved here in the mid-'80s, it is now no longer majority African-American. It's about 46%. So you have almost double the number of people that the city demographic who are actually dying of COVID. So the question becomes, why do these groups do worse? Is it lack of insurance? Is Medicare for all the answer? Certainly when you listen to the various political platforms, you hear that sort of the panacea is going to be free insurance for all. And certainly access to healthcare is important, insurance coverage that is comprehensive and not, these high deductibles is important. Through the Affordable Care Act and expanded Medicaid coverage, we have seen the needle move in a positive direction on things like improving Latina maternal and infant health outcomes. That's just but one example in those states that have expanded Medicaid. But if insurance, having health insurance was the reason that we would have great outcomes, DC would be only second to Massachusetts in having excellent outcomes. And in a minute, I'll show you that we don't. Massachusetts has 97.2%. We've got 96.8%. And I will tell you, DC has always been progressive. AIDS was always a Medicaid qualifying reason to get insurance. And so, of course, with the Affordable Care Act, more people were covered. So we've got pretty good insurance, and we've got wonderful FQHCs and access to free clinics, and many of our hospitals, well, they give free care and then write them off as tax write-offs. So there's incentives there. So is DC the second healthiest? Well, first of all, we're not a state. We are considered a territory, which is interesting because we pay taxes. And just as an FYI, we got 3/5 of all the other states for the stimulus package. So right now in DC, we are experiencing, at the height of COVID, a $750 million shortfall. And so you know what that happens, what that means. What that means is programs for children, for vulnerable groups, for the elderly, for the disabled are being cut. And of course, I should tell you that all those parades and various administrative, whatever you want to call them, celebrations, we have not gotten paid as a city. Millions of dollars have been owed by this current administration. So why is that? Why is it that we have such poor outcomes? Well, and forgive me for those of you that are familiar with these concepts, I just want to make sure that everybody is on the same page. The social determinants of health. Where you live, the air you breathe, the water you drink, your educational level, poverty, the economic health of your community. I really like, sorry, somebody is not muted, so I'll just kindly remind you to please mute your buttons. Thank you. That, we have to look, this is from the Kaiser Family Foundation, and what I like about this at the very bottom, it looks at health outcomes. Not just mortality, but of course, morbidity, the quality of your life, your healthcare expenditures, because poor outcomes cost a lot. Your health status, your functional limitations. So you can look at all of these, different sort of pillars that I mentioned that are key to that. The healthcare system actually explains less than 20% of health inequities. It does only account for that, but if you have cancer, having timely access, it's 100% of your health outcome, right? The technological innovations, the immunotherapies, the rare diseases, it would be silly and ridiculous as a physician to say that we're not important. We're crucial, but I think sometimes we overestimate our role. I think one of the problems that we have seen uncovered with the COVID pandemic is not giving and not investing in the public health systems, which really have been the difference between containing this virus and then having such an incredible, devastating impact, both health, life, education, as well as the economic devastation that we have. So we have to figure out where we keep the best of the innovations and all the positive things of which some of us are beneficiaries, but also to really stress those other measures that we know work. So let me introduce you to Washington, D.C. Probably a lot of you have come to D.C. for various conferences. I know AAIM had a recent conference here. And what I like to say is that D.C. is like a diamond in the sky. And so on the left, you see the beautiful Potomac River. That's where all of our beautiful monuments are, the Lincoln Memorial, the Jefferson Memorial. Ward 1 is where Congress is. And then there's another river that is sort of divides the city into the southeast quadrant. That's where Ward 7 and 8 are. I live in Ward 3, and you'll see in a second where all the hospitals are located. And the span of this city is only 10 miles. I should tell you that like many other urban cities, there are clear divisions. And if you want to read a really good book about the history of redlining and also sort of the divisions, there's the Division Street, written by Studs Terkel, who has since passed, about Chicago. And really, literally how there's a division street between the black sections and the white sections. In DC, it's a little bit different because Georgetown, which is the wealthiest ward, actually was the place where African Americans used to live. So the oldest African American church, in fact, is in Georgetown. Capitol Hill, which had historically been also an African-American community, is now changing. Lots of change, lots of gentrification, lots of people being displaced. We don't have a Ward 9, but people who live in Ward 7 and 8 are being displaced into Maryland. So sometimes you will hear people talk about Ward 9, which is Prince George's County, which is sort of an extension of Ward 7 and 8, really Ward 8. Ward 8 is the poorest of the poor. And I just want to say, I'm going to be talking in sort of generalizations, but these are human beings, these are communities, these are neighborhoods. Ward 7, for example, is a much more heterogeneous neighborhood than Ward 8. Ward 7 is kind of like two wards. One ward is one section of it is where a lot of the retired federal government workers live, a lot of homeowners, a lot of professionals. And then the other part is more like Ward 8. Ward 7 and 8 is about 180,000 people. If you want to really look at an extremely well done study out of Virginia Commonwealth University, I would really recommend Uneven Opportunities. And really, if you just want to scan the graphs, I think that that will tell you all that you really need to do. It's an in-depth study, a granular look at DC, Maryland, and Virginia, Kaiser funded. In DC, if you live in Georgetown, I told you is the wealthiest, you can expect to live on average 94 years. That's pretty good. That's higher than the national average. But if you live in Anacostia, which is in Ward 8, that number goes down to 66 and a half years. That's almost 27 years. And part of what drove me to start the Rodham Institute in the first place is that here we are living, I'm living in Washington, D.C., the capital of arguably the richest country in the world, and we have a almost 27 gap in life expectancy. But there's more. We're number one per capita in cancer mortality in the country, HIV, cancer, end-stage kidney disease, and Ward 8 has the same HIV rate as Namibia and the same infant mortality rate as El Salvador and Cambodia. I mean, this is just unacceptable. I'm sorry, my PowerPoint skills are not great, but this basically illustrates that. Please go to Uneven Opportunities, and really kudos to all the people that were involved in that wonderful work, because it is important. Here are the poverty rates in DC. Now, I told you I live in Ward 3. The poverty rates, though, there are not zero. They're 9%. Ward 8, it's 37%. And it's important that we recognize that there's food insecurity, even where I live. It could be among shut-ins, the elderly in particular. They are particularly prone. But on average, the people who live in Ward 8, their mean family income is $220,000. In Ward 8, it's $37,000 for a family of 4. Let's take a look at grocery store distribution. Again, you can see that there are hardly any dots, right, in Wards 7 and 8. And there are lots of corner stores, lots of takeout, especially Chinese food and fried chicken. Recently, there was a renovation of a full-service Giant, but I can tell you where we work, Dr. Onama and I at GW, every time you turn around, there's a Trader Joe's, Whole Foods, all these restaurants. You're practically stumbling or tripping rather over all the different options that you have. This is really a dirty little secret that we have in the United States. I think we sometimes look at sort of developing countries and, we talk about, I'm of African descent. I was born and raised here in the United States. I'm not part of the African diaspora, but, everybody always talks about how children in Africa are always going hungry. Well, children in the United States are going hungry too. It's estimated, well, here are some of the examples, of food swamps and deserts. When I go to corner stores in Southeast, I am shocked at the variety of potato chips that there are. I have never seen so many different types of potato chips. Also never seen such huge cans of beer. And there have actually been studies that look at the sizes of chips and alcohol in Latino and African American communities as being at least 40% larger, not to mention the different types of candy that are sold there. And lest we think that people in those communities don't want to eat fresh fruits and vegetables, because I think, we tend in medicine, especially as internists, to be kind of, maybe not internists, but at the whole system, general internists, I think we're pretty cool, and we tend to be understanding, as well as pediatricians. I'll just give us a shout out, and psychiatrists. But I think we tend to say, well, these communities really don't know about eating healthy foods. And I just want to remind people of a little story. Ward 8, within Anacostia, there is Berry Farm, and sometimes people think that it was named after Marion Barry. It's not. It was actually the Berry Farm tobacco plantation. And after the Emancipation Proclamation, the freedmen were given 400 acres, and they parlayed those 400 acres into a thriving African-American farming community. And after they tilled the land by lantern, they would walk all the way across the river to where Howard University is, and they built Howard University. So at its heyday, 1 in 4 adults were students and enrolled at Howard University. Now 1 in 4 are in the prison system. So when I talk to some of the elderly residents of Southeast, or the East End, sometimes people like to refer it to their sort of different schools of thought about what it should refer to. That's why you're going to hear me use those terms interchangeably. People will say, yeah, I remember, picking an apple from the apple tree and eating it. And indeed, when programs such as DC Greens, who has a healthy corner stores, they partner with corner stores and say, look, we will bring the produce, we will set up the stands, and you can make the money off of the fruits and vegetables. And within like an hour, all the fruits and vegetables are sold out. So this myth that people don't know what to eat is not true. Maybe some people need to be educated. Maybe people need to have their taste buds changed. It takes about a week to get off salt and about a week to get off sugar. But if given healthier alternatives, I can tell you the majority of people will choose those. Now, one thing that I did not know that I learned from my colleague, Dr. Michael Compton, who edited this book, The Social Determinants of Mental Health. He actually was at GW as a faculty member. He's now, I believe, in the New York State Department of Health. That food is the strongest determinant of mental health. So I remember long ago when I used to bring a patient to the medical students, I brought a homeless gentleman who had AIDS, and at that time, patients stayed in the hospital for 3 months, sometimes longer. And one of the medical students stood up and said, I always wonder, when I see a homeless person, should I give them money? And the guy said, no, give them food. Because, many people are mentally ill, many people have substance abuse who are homeless, but people can't afford a good meal. So in his honor, that's what I always do. And actually, the severity of the mental illness is related to food, and any kind of food. I'm not even talking about healthy food. I'm just saying any sort of food, which makes sense. I mean, that's our basic survival. And anybody who has children or any adults, for example, think about how you feel when you haven't eaten and it's time to eat. But I will just remind everybody what's happening to kids who are in Title I schools and who, now that we're going to virtual learning, who rely on free breakfast and lunch, and sometimes even more, sometimes three meals. What's happening to children for whom school is a refuge and a lifeline? We're hearing that things like child abuse, domestic abuse, domestic violence, those things are really going up. And school was a place where a lot of the reporting was happening. We've got an excellent sort of public or school health system that our Children's National Hospital runs. And this is a real concern in this COVID. This is another shocking statistic. Only 42% of kids in Ward 8 graduate from high school. And if we did nothing else as physicians or as clinicians but getting our kids to graduate from high school, we could add 10 years of life to their life expectancy. And I will be wrapping up because I just got a friendly notification from Dr. Onuma that I'm already into Dr. Anthony's time. So just really quickly, telehealth and teleeducation, we've adapted quickly. The healthcare system has also had to adapt, but how do communities of color fare? The digital divide is no joke. I'm on the mayor's committee to reopen DC, and we know that not all parts of DC or other urban or rural areas have internet. Families who do have internet have had to decide between continuing their internet or paying their bills. If a family has a computer, it may be shared among 3 children, and then 1 in 3 people are functionally illiterate. So, we don't even know about the digital literacy. So we're relying on parents, right, to teach kids. We actually, with our kids, we have some pipeline programs for middle and high school kids. And especially the high school kids are really demoralized because they're having to take care of their younger siblings while they are having to go to school themselves because they're members of their household, their parents, grandparents are trying to hold on 2 to 3 jobs. All right, we will talk about solutions. I'd be happy to talk about that, but I want to be respectful of your time. We can come back to that in the question and answer period because I do want to leave you with some hope. The problem has been studied. I do believe we can make a difference, and I look forward to the discussion, and maybe somebody will be kind enough to ask me the question in the answering questions so I can share with you some solutions. Thank you for your time, and I yield my time back to Dr. Onuma, and thank you for your time and attention.
Thank you, Dr. El-Bayoumi. We certainly look forward to hearing more about the solutions because I believe that is really why everyone is here, to learn from your expertise. So I really appreciate you. We do have another poll question to make sure everyone's still there. How confident are you in your ability to affect change related to inequities in healthcare, and specifically as related to COVID-19? All right. And we'll be transitioning to Dr. Anthony now, who will go over a little bit more of some of the solutions in affecting change here, and he can discuss these poll results.
You're muted, Dr. Anthony.
Thank you, Dr. Onuma. And thank you, Dr. Bayomi, for your presentation. I think what I have to present is actually a perfect segue from what you've already shared. And it's kind of based off of just my experience growing up and then my experience transitioning into medicine and becoming a provider or clinician myself. Uh, so on April 7th, 2020, the country discovered that health disparities exist. Um, and in the words of, the notorious B.I.G., if you don't know, now you know. I remember I was sitting on the couch when Dr. Fauci gave his presentation at this press conference, and although it wasn't a surprise to me as someone that has Black family members, has participated in healthcare for the Black community, most of my time being involved with medicine. It was surprising to me how surprised the rest of the country seemed to be at some of these facts. So just in general, African Americans are more likely to die at early ages from all causes. And I'm not going to go into specifics because I believe Dr. Obayomi did a great job, sharing what some of the challenges are for the African American community. But I'd like to ask why. Of course, Dr. Obayumi presented social determinants of health, which have a huge impact on just the community's ability to be healthy, live healthy, pursue happiness, and kind of have a productive and meaningful life. I kind of like to look at the cause from the lens of, or at least look at access to healthcare services through the lens of social engagement and community involvement. So even though the cause is multifactorial, clinicians have actually always played a pivotal role as change agents, even though that role has not always been positive. So I think it's important to note that when we as clinicians ask about or want to know what our social involvement should be, if any, we should understand that we have always been involved. And our involvement historically has actually led to the complicated relationship that communities of color have with the healthcare system in general. We have the Tuskegee syphilis experiment as example. We have examples of Henrietta Lacks and having her cells taken without her knowledge. We have J. Marion Sims, who's considered the father of gynecology, and how he experimented on the bodies of Black women in order to make the discoveries that he made.
Dr. Anthony, I think you have some wonderful visuals to share with the audience. Would you like to share those as well?
Visuals, are they not showing? Oh, I'm so sorry. Yes.
Well, we know you worked so hard for those visuals, so I want to make sure the audience can also appreciate these.
Thank you for that. Is it showing? Okay. All right. So, as I was saying, here are some of the examples of, ways that clinicians have played a role as change agents, although unfortunately not in positive ways. So I believe that, we really have an opportunity to change that around now, um, and kind of stand behind endeavors that are more positive and that, can actually bring health to different communities of color. So I like to start, talking about my grandfather, Carl Robinson Jr. He's a Black man. He's a World War II veteran. He's an entrepreneur, a husband, father, and my grandfather. But one thing I remember about him is that he absolutely refused to go to the doctor. And I bring him up because, even today, my grandfather was born in 1912. He died at the age of 92. However, those same kind of attitudes and dispositions exist within the African American community, and for good reason. If anything passes from generation to generation, is trauma. And so him being alive during those time periods and actually seeing those things with his own eyes, him actually being a World War II veteran, but at the same time coming back home and being treated as a second-class citizen when it came to protecting his family and protecting himself. The message was, the doctor is not someone you go to visit to get better. So unfortunately, even today, there is still definitely validity to those kinds of feelings. Back in April, one of my colleagues, Dr. Malam, he headed this article that he actually gave us the opportunity to help him with. Are clinicians contributing to excess African American COVID-19 deaths? Unbeknownst to them, they may be. And really, this article took the time to just compare the kind of care that African Americans already receive for different conditions, and kind of investigate the attitudes that clinicians already display, and how things like implicit bias actually have a huge effect on African American care and even mortality among African American patients. So, unfortunately, while disparities, health disparities are high, you kind of see the inverse when it comes to the number of Black and brown healthcare providers that are present. According to the AAMC, only 5% of all active physicians are Black. You can see in the chart, 5.8% of active physicians are Hispanic, and then less than 1% of active physicians are Native American. And I believe that this kind of affects access to care in two ways. One being, of course, the quality of care that you receive, but also on the other side, from the community engagement or social engagement, community involvement side, you've probably heard this before, but representation matters. So this is Joshua Anthony, Black boy, a future physician, an entrepreneur, son, brother, and friend. But he did not encounter a Black male physician until adulthood. And it's interesting because my experience with, coming into medicine was, one, by the age of 7, I was absolutely sure what I wanted to be. I knew that I wanted to be a physician, and I did not deviate from that all the way until reaching medical school. But at the same time, when I finally met a Black male physician, was actually on my last day in my hometown before leaving for medical school. And it was actually at the exact same community clinic where I had gone all my life, where I had gone as a child. So for me, there was always that irony that, as I was leaving, for the very first time, I'm actually seeing this for the first time. And because I never saw African American male physician. I also never had certain things like physician mentors, even though I volunteered at hospitals or tried to do other things to kind of get experience. For me, it was always like I was kind of invisible to the physicians that were there. And so it was kind of my entry into medicine was kind of a self-determined effort. It was kind of, I'm going to keep pushing until I get it. So after Dr. Fauci gave his presentation, I talked to some of my colleagues and wanted to really flush out, what is something that we can encourage people to do as clinicians. And we came up with the disparity challenge. So number one being, be aware of and work to mitigate your bias. Most people have implicit bias, but the thing that I guess is insidious about implicit bias is that most people don't realize it. And when you're in a field of human services where you can actually affect whether or not someone can lose their life, it becomes extremely important. So a very easy way to kind of become aware is something called Project Implicit. This was a project started by Harvard University. And it's pretty much a simple test that kind of tells people if they have implicit biases towards certain things. I've done it before in the past, and I thought it was very helpful. Now, how do you mitigate these biases after you realize that you have them? For me, I like to tell people the opposite of what I tell them, regarding COVID-19, which is get exposed. It's impossible to mitigate, biases when you stay isolated and secluded from groups because you tend to work off of generalizations and stereotypes. So start spending times in communities where you give care, start participating in, different kinds of services, and not just from from the perspective of providing services. Start actually engaging with, people that are different from you. Advocate for all patients equitably and without preconception of status or class. I actually changed it from what it was before. Initially, I had said advocate for all patients equally, but as you'll kind of see in the slide, that is not always enough. So if you look at this chart, I'm sure a lot of you have seen it. The reality is that, those who have the least often get hit the hardest. Um, Now you can treat everyone equal, but that won't necessarily allow everyone to be able to improve or to gain health equity. So when you move to uh, the idea of doing things equitably, you start to embrace the idea of speaking up the most and providing more for people who need it more. Until one day, hopefully, we can reach the stage of liberation where that's not needed at all. Educate and engage all your patients in a way that is respectful, sincere, understandable, and culturally competent. When I think about this, when I first started working in healthcare, we kind of would say, treat your patients the way that you want to be treated. But I think a better rule of thumb in general is treat your patients the way that they would like to be treated. Um, what you don't know may not hurt you, but it could hurt your patient. So I think a good rule of thumb is if you don't know, ask. This one is very close to me, and I guess what I try to do personally, how I try to reach out to younger generations, which is decrease the disparity of diverse healthcare providers within your specialty through visual representation and by mentoring Black boys, girls, men, and women who are interested in the health sciences. This one is really close to me because I didn't have this when I was younger. I didn't have the visual representation really. And then I didn't really have the opportunity to be mentored by anyone. So today we have, social media, which is just absolutely great for the purposes of being able to reach a large number of people wherever they are without having to worry about distance or some of the other barriers that would normally exist. So these are some of the things or projects that I've worked on social media to increase representation. So there's Mahari Made, which is a social media page that I made kind of to boost representation of, all the Black physicians and dentists and researchers that are produced by Meharry Medical College, and to kind of allow young children to see that, a lot of these people are just like you. They came from your same community. RMRN is a group of Black men physicians, and we kind of got together with the idea of, just providing a positive image of a group of Black men working together and pushing different social endeavors in kind of amplifying each other's voices whenever possible to reach more people. And then the last one was, the End of the Disparity challenge, which was a few slides back. And we really just called for everybody, anybody that, was working in healthcare to, hey, take this challenge, start taking actionable steps to decrease disparities, both by reaching out to your patients, but also by increasing the number of Black and Brown providers within healthcare. And I'll show you kind of some of what we've worked on as a result. So it's just an example of like some of the challenges that, as Black men that we've had to face to even get into the field of medicine. Um, so next step, financially contribute to organizations and institutions whose goal is to increase diversity within the health sciences. For me, I'm biased. I'm a product of HBCU education. And so just in general, facts are that HBCUs contribute or produce the most number of Black doctors, engineers, and lawyers in the country.
Many of you could have attended any school in this country, but you chose an HBCU specifically because it would help you sow seeds of change. You chose to follow in the fearless footsteps of people who shook the system to its core. Civil rights icons like Thurgood Marshall and Dr. King. Storytellers like Toni Morrison and Spike Lee. You chose to study medicine at Meharry and engineering at NC-A&T because you want to lead and serve. And I'm here to tell you, you made a great choice. Many of you could have...
So you can imagine when he mentioned Meharry, I got very hyped. But I think donating, financially contributing to HBCUs, which unfortunately are still very underfunded, is never a bad choice. The last part is work to actively address the social determinants of health at a local and national level. So that's doing things like voting, getting involved with organizations like the Rodham Institute, and getting involved with policy at the national level to actually see things change across a wide area. So.
Wonderful. Thank you, Dr. Anthony. We certainly appreciate it. So, in the interest of time, I think it was a perfect segue, and I feel like our participants are actually looking for some concrete ways and solutions to addressing some of these social determinants of health. And so there's been a few questions in the chat box. I'm wondering if Gigi, if you can share some of the information on concrete ways in the community that people can actually affect some of these social determinants and decrease some of the COVID and non-COVID related inequities.
I would be delighted, Dr. Onema, and I'm going to bring back my slides and kind of continue. I just want to congratulate Dr. Anthony. I had seen his work on LinkedIn. Actually, that's how we connected, and it's interesting. One of the people that he had there was one of the former residents who's a fellow in cardiology. So I'm just very proud to see Dr. Ashby mentioned there, and you can see the importance of having younger voices, very creative. And so thank you, Dr. Anthony. I'm so proud of you. So yes, we have know the problem, but there are lots of solutions. And really, I think one of the things that we learned at Rodham at the very beginning is first, in your zeal to get started on doing something, ask first. Find out what's already going on in the community. Sometimes we act like there's nothing that's happening. There's a lot that's happening. And our role as academic institutions should be humble consultants. We serve at the pleasure of the community in the way that they want us to. Let me tell you about UC Greensboro. University of Carolina, Greensboro has a wonderful program which is actually moving the needle on both lung and breast cancer mortality for African American women. And guess what? White women also benefit. Assistant Professor Crystal Dixon is somebody. We talked about helping to increase the number of Black and Brown physicians. Let's not forget that the people that we work right alongside with, and those are the staff, that's a group of people we forget about. Having the kids of staff, the medical assistants, the custodial staff, these are people that are actually, these children are primed to do better because they're family works in a healthcare system. Well, that's one of the groups that we have make available our programs, the Health Education Leadership Program, and try to reach out to kids that may not be the gifted and talented. There are more programs for gifted and talented than not. We know that having physicians that Black male physicians in particular, this has been studied very well, make a difference in Black male health outcomes. Does that mean that non-Black physicians don't have a positive outcome? Of course, that's ridiculous. But there is something about feeling comfortable when you are, facing an onslaught of racism. Don't forget, a lot of folks have PTSD, post-traumatic slave disorder. And so sometimes people will react not to you, but who you represent. So never be offended. There's a lot that triggers people, just like some women prefer women gynecologists because they may have been sexually traumatized. It is also true that people have different preferences. Let me tell you what we've been doing, because I think that these are easily replicable. In our part of town, when I was working in the hospital, I can't tell you how many free meals we were being offered as clinicians. But guess what? In the only hospital that's in Southeast, people there in regular times, the cafeteria closes at 3, Monday through Friday, is not open on the weekends, and is closed between 11 and 12 Monday through Friday. So trying to get meals there. Churches, Southeast Tennyson Learning Center, which is for children and families, homeless residents. We also have been, we've delivered through Ms. Christina Williams. She's in charge of our community engagement, food and mass, something like over 2,000 meals and produce boxes, and now 2,400 masks. We've also been putting on webinars. I'd invite you to go to our website, and they're all online. Food donations. I mean, if you want to just personally give to the food banks and the Red Cross, especially with the devastating natural disasters that are happening, here are some of the pictures, some of the wonderful resources that we've put on our website. And here you can learn more about our priority areas where actually programming, education of all of us, including through webinars, community collaboration. So donate, donate, donate. I don't want to forget Zaina Houri, because she actually helped me with this presentation, and here are our wonderful staff. So it doesn't take a lot to do something. I think sometimes we get worried that we have to do grand gestures, but just like what Dr. Anthony mentioned, we can do little things just by having a child come and follow us to see what we do, to get exposed, if we're not of color, to other people of color. If you just think back to your own experience about what turned you on to medicine, and it doesn't also have to be physicians. There are wonderful colleagues all through the healthcare system, including health IT, public health. Just exposure, I think, is so important.
Thank you. Excellent points, Dr. El-Bayoumi and Dr. Anthony, for your inspiring ways that we can help affect not just COVID-related health inequities, but inequities in general. So I do want to see if there are other questions I have another question waiting, unless, let's see if any of our participants would like to ask our panelists any questions. You may enter it in the chat. While we're waiting to see if there are more, I want to ask either Dr. El-Bayoumi or Dr. Anthony, there are a lot of social inequities or social determinants of health. What ways do you think, if you had to choose one priority, top priority as physicians to actually tackle to make the most impact, what do you think that would be?
I'll yield to my colleague first.
For me, it would be increasing the number of Black and Brown healthcare providers, because there's already a significantly low number of Black and Brown providers among physicians, but just the number of active physicians in general is decreasing. At the same time, number of patients are increasing, and so if like COVID-19 has been any indication, we need to increase those numbers. But not only that, patients, Black and brown patients, they're more likely to follow recommendations, to even, come in to see the doctor, if they know that they're able to see somebody that understands their background, their culture, someone that looks like them.
I would add what the very first summit that we had in 2013, we asked that question to the 100 participants that were a diverse group of people within the healthcare system, from the community, people with formal sort of community-based organizations, local government, federal, et cetera. And we said, what should we focus on? And resoundingly, everybody agreed, which, as you know, in Washington, D.C. is a very rare thing, that it should be education and food. Food, I told you I wasn't, I didn't really appreciate that aspect, but those are the things. I think also, as physicians, we don't always feel it, but we can leverage our influence, right, to say, look, going to Dr. Anthony's point about equity, here in this side of town, they've got these school nursing programs and, all this kind of stuff. Well, we should be allocating more of those programs to the other side of town where they actually have a bigger need. I also just want to answer a question that I saw come across the chat about, do we think that there was harm in not having medical students be on COVID? That's be involved in the care of COVID. I have to tell you, that's a sore spot for me, especially since I volunteered actually to take care of COVID patients in the hospital. And, I'm more at risk. I'm 61, I'm older. And I was really shocked that was a decision that our medical school, but I think many medical schools made. I talked about, AIDS, and, it was 100% death rate. And we didn't even know what the mode of transmission was. So I think it does a disservice. I mean, I understand now we're worried about liability and so forth, but what kind of a message are we sending to future physicians that know you can opt out? I mean, that kind of goes against the oath that we took. I mean, there may be reasons for people to opt out. Look, if people have if they're, immune deficient or have certain medical conditions, by all means, or they're living with somebody who's at high risk. I don't want to be judge and jury, but to kind of just blanket say that no medical students will be there. And then what did that do for the medical students that started as interns? They lost like 6 months of valuable training time. Not that
Valid point.
Yeah, not that fourth year is always can be a picnic, but
but Dr. Obayumi, that brings us to, we have a few questions surrounding trainees and education. Rightfully so, a number of institutions are trying to beef up, if you will, their teaching about surrounding health equity, racism and things. And so one question is it problematic for, white physician educators to teach healthcare disparities and social determinants of health? I have my own answer. I hear heads shaking no. Right. So I will say, as a person of color that does some of this work, we're exhausted and we're drained, and we want as many people that, now I think it's important to, relate and make sure that you are listening to the communities that you are teaching about and including them in that training. But anyone can teach about this as long as you have done your due diligence and actually getting the information. And the historical aspect, I think, is really, really important.
I would also add that just because you're of color does not necessarily mean that you're going to be sensitive. I mean, I made the distinction earlier by saying of African descent, but not of the African diaspora. Sadly, we know that people who come directly from Africa may look down on African Americans. So there can be that. So we actually have, and I would invite people to sign up for our next one, Unpacking Whiteness. And we had an incredible panel of all white folks that talked about that. So no, it's not. I think, like you're right, it's tiring to keep having to explain.
Yeah. And then one more question I want to make sure that we answer surrounding trainees again too, is a trainee that is personally experiencing or seeing systemic racism in their own institutions and what have you. How can they address that? What recommendations do the panelists have on addressing that in real time? So not the, mentorship and any thoughts in the moment?
I always, try to close my mouth because I know I can always talk. Dr. Anthony? Well, maybe I'll just share what happened to me and how I answered it. One time I was sitting, I was a junior faculty, I wasn't a resident. Well, yeah, I mean, there's there's so many examples, but this is the one that comes to mind. And we were on the intern selection committee, and the chair of the department at the time said, if we are not careful, that parking lot will turn into a camel lot full of camels across the street, because they were worried about, who was being admitted to internship. And I turned and said, whatever do you mean, Dr. So-and-so? Oh, I didn't mean you. I said, well, just given all the racism, I'm just surprised that you would say that. And what was so disappointing to me, I was a low person on the totem pole and nobody spoke up. But you better believe that sort of never came up. I think it's very hard to answer in the moment, especially when the power dynamics are such of repercussions. I think it behooves those of us that are more senior to actually call it out, because, people are afraid. I mean, we had an instance recently where actually the person went very high up, and person said, are you sure that this happened, or that you heard that right? And nothing happened to the offending faculty members. So it is very complex, but the onus shouldn't be on the person with the least power. It should be on people such as myself and others who really have nothing to lose by speaking up.
Thank you. Thank you. I think that's a perfect segue. I think hopefully we'll all feel empowered to speak up and empowered to speak up for others if we see things that are not right. And then the structural racism, we know that that's going to take time, and it's all hands on deck, essentially. So that was our Q&A. I want to be mindful of everyone's time again, and especially with everything that's going on. We do want to make sure that we share some additional resources for you all. Hopefully you've learned some new things, or at least opened your horizons and thinking about ways that you can impact some of the inequities in your own institutions or communities. And, I think there is something for everyone, little bits or even larger change as well. So continue the conversation on Twitter, #AAIM webinars. You can also continue discussing this with colleagues surrounding diversity, equity, and inclusion issues in the AAIM resources folder. There's a number of ways to connect with colleagues, including myself. And then you can also tell your colleagues about the AAIM Health Inequities webinar mini-series and join our next session in September, which will be talking more about the patient perspective, which is really, really important. We want to make sure that we're focusing on our patients. We do invite you to share your feedback so we can make these webinar series as applicable as possible and as learning opportunities so that we're all learning and growing together to make a positive impact. So you can use the following SurveyMonkey link to share your feedback. And again, that's the next webinar series is September 17th, 2023 to 4:30 p.m. Eastern Time, the COVID crisis and health inequities, the patient perspective. Thank you all for joining us.